Wait a few seconds here. It takes time for us to get everyone who's in the queue, and then we'll start our session. I'm so looking forward to having this opportunity to have a chat with Peter. And so if you just stay tuned and be patient just for a little while, and then we'll get started. Thanks. These are always like awkward moments when you're just ready to go and you're just like waiting, but we'll be patient. I think we'll go ahead and start now. Good afternoon, everyone. Thank you for joining us in another session of our In the Arena series, and this one's on COVID-19. We are so pleased to welcome the president of Baylor Scott White, Peter McCanna, who has served in this position since 2017. Baylor Scott White is the largest not-for-profit healthcare system in Texas and one of the largest in the United States, with 52 hospitals, over 800 patient care sites, more than 7,300 active physicians, and over 49,000 employees. With this reach across Texas, Baylor Scott White has experienced the diversity of care issues presented by the virus. President McCanna was brought in to improve agility and nimbleness of the system, with the aim that Baylor Scott White would be a model integrated system. This is especially significant in the world we live in now due to the pandemic, where shifts and demands for hospital care are constant and they vary across region and within communities. So President McCanna has been in hospital administration for more than 30 years. And his most recent, obviously, is Baylor Scott White. But before that, he served as Executive Vice President and Chief Operating Officer at Northwestern Memorial Healthcare in Chicago. During his 15-year tenure at Northwestern, he helped grow its operating revenue from $700 million to more than $5 billion. He was the Chief Financial Officer of Presbyterian Healthcare Services in New Mexico, which gave him, again, a broad operational disposition within the hospital administration. And also he served at the University of Colorado Hospital in Denver prior to joining Northwestern. As you can see, he has a robust set of experience in hospital administration. And we are also proud to say that Peter is an alumni of the LBJ school. So he's been at Ground Zero, and now he's responsible for medical facilities that are and have been in the forefront lines of the coronavirus. So welcome, Peter. We are so pleased to have you here.
I'm very pleased to be here and speaking to you, Dr. Evans, and doing this related to the LBJ school, which gave me great training for what we're faced with today.
Thank you. Let me just get right to the questions. Peter, what has COVID-19 revealed about the state of the healthcare system in Texas?
Well, I think the central issue about Texas healthcare, I think it dominates virtually every public health issue and dominates economic issues in Texas, is the rate of the uninsured in Texas. And it manifests itself in different ways. I mean, before the virus, 1 in 5 people in Texas during a year found themselves uninsured. And now, with the economic consequences of the virus, we're looking at almost 3% of Texans at some point during this pandemic have or will find themselves uninsured. And that has significant impacts on the health of Texans. Obviously, access. If you're uninsured, you're less likely when you feel symptoms to go to the doctor or to go to an emergency room. And if you're uninsured, you don't have the kind of access that those of us who are insured have. And the economic consequences are significant. Employers need healthy workers, particularly during the pandemic. And without expanded insurance coverage in Texas, it could have negative consequences on business growth and businesses getting back to normal operations. So I think that's the central issue. We've seen, and it's related to lack of insurance, but we've seen the impact, we've seen the national statistics, and it holds true in Texas that the virus has a disproportionate negative impact on people of color and underrepresented minorities. And so the infection rates are higher, the hospitalization rates are higher than what percentage that these socioeconomic groups represent in the overall population. So it's really, insurance coverage is a big deal.
Mm-hmm. And what you said too, it's not just about COVID-19, it's the general health of the population, because what we've also seen through COVID-19 is folks with other conditions, whether it's high blood pressure or heart or stroke, or some people are reluctant also now to go to hospitals, not only because they're concerned about COVID, but they don't have the resources also to use hospital care, which often is the last resort for some of these folks. So this is bigger than COVID is what you're saying. It's just COVID has unveiled and revealed many underlying conditions that were fairly well, I wouldn't say fairly well operating, but were hidden in a lot of ways from the public.
Yeah, I think there's another impact, and a lot of these have overlapping impacts, but particularly during the shutdown in April, one of the big concerns again was access. So access already constricted for those that are uninsured, but then access for the general population for those people with conditions that may not be COVID related. And so we saw admission rates for stroke drop precipitously. We've seen reports out of EMS services that indicated that the number of calls they have for cardiac codes went down dramatically. And it's not like the incidence of those things went down. It's that people actually during that period went untreated for those conditions. So we've made a large effort. We learned a lot during the shutdown and made a large effort to make all of our care locations safe. We learned a lot about PPE. So what we've found is that the PPE works. It works for the care providers. It works for the patients. And that we've really done a large communication campaign out to our patients and our physicians and our communities saying it is safe to come in and get care, because we became very concerned, obviously for the COVID patients, but also for patients that had urgent conditions that were COVID. And we are starting to see those patients come back in.
Good.
So that's been a positive lately.
Peter, I have a question in the chat that I want to get to. Some people could not hear the audio cut out when you were talking about the rate of uninsured post-pandemic. Can you repeat that for the listeners?
Yeah, if you look at the unemployment rate spiking, the estimates are that 30% of Texans in any given year will go without insurance. Prior to COVID, that was about 20% of Texans. So you're seeing a broad impact of the lack of insurance being exacerbated by the economic consequences of COVID.
Good. Well, I want to get back to some of the things we talked about earlier in our conversation, and there's two streams I want to talk about here. One is as a hospital who had to deal with the pandemic very quickly and get things started up, get the equipment you needed, getting the community educated. What were some of the obstacles you faced in doing that for the broad network that you have here in Texas? And we talked specifically about policies, already existing policies, when we're talking about Medicare, Medicaid here, but other policies that you found to be obstacles to your ability to get yourself ramped up very quickly to take care of patients for COVID. So that's part one. Part two is, have you seen any relief from those obstacles if we come up with another surge in the pandemic?
Yeah, when
Sorry, I'm so sorry.
that's right. When we first started treating COVID patients, and we've learned a lot since then, the most immediate concern initially was safety of our staff and the safety of patients. We were looking at some of the experience in Italy, and what they found in Bergamo in Italy was that actually the hospitals were contributing significantly to the transmission of the disease. That they for whatever reason, they were the hotspots for spreading the disease, and we didn't want that to happen in Texas and the United States. So we immediately implemented procedures and policies to eliminate and reduce transmission. The obstacle we ran into was the availability of PPE. It was not widely available, particularly N95 masks were not widely available, and we didn't know a whole lot about the disease actually that we do today. Now we understand that virtually any type of mask can reduce transmission a lot, whereas back then we were pretty much solely focused on N95s, which created a worldwide shortage. We had other strain shortages that interrupted the treatment and diagnosis of the disease. Turned out that the nasal swab that's used to take the test for COVID-19, with the largest manufacturer of those swabs was in that portion of Italy that was hit so hard as a hotspot. So things like that initially really were major obstacles. The second obstacle was really around communications and guidelines. There were national guidelines coming out of the CDC. There were state guidelines and pronouncements coming out of the governor's office. And then every community has its own public health agency that would be applying some other guidelines. And we run a health system in dozens and dozens of counties in the state of Texas. So coordinating what is our policy, what is our approach in the context of the various government guidelines. And we generally would default back to the most stringent, the safest guideline that we believe was out there. But if we go back over those months, those guidelines changed day by day, week by week, month by month. So we had to be very flexible in pushing that forward. But I would say the PPE was really, really concerning. Then when the shutdown came in April, as I mentioned a little bit earlier, that became a major barrier. The barrier was, are we going to have enough staff show up for work? Another barrier was, are patients who actually need urgent conditions, are they fearful of coming in? And how can we reach out to them in a way that reduces that fear? And again, how do we control the transmission in a way that we aren't unintentionally spreading the disease? We went very quickly to expanding our digital capabilities. So we had a mobile, digital, online screening tool. If you screened not positive, but as a potential COVID patient, we immediately sent you to either an e-visit or virtual visit, where a physician then evaluated you. If you passed through that screen and you were a potential, what we call a PUI, and have potentially had COVID, then we sent you to a testing center, and oftentimes had drive-through testing centers. So we tried to close the loop on that so that patients weren't all arriving at clinics and then potentially infecting other people. So really worked on those obstacles early on. Many of those have been removed now. PPE now is fairly abundant. We've moved to really increase our stores of PPEs because we anticipate until there's a vaccine, we're going to have multiple waves of COVID in Texas, and it'll vary by community. We've learned a lot about the therapeutics for COVID. Obviously, there's not a cure, but the use of common steroids, a treatment where the patient is put in a prone position when they're admitted, improves their breathing. Using high flow oxygen devices rather than ventilators is improved. We're a health system, so we're advantaged now in that we'll have some hospitals overwhelmed with COVID patients and other hospitals with excess capacity. We were able to move staff around the state of Texas. So where there was excess staffing, move it to areas that were stretched for their staffing. And actually, in some regions, we're able to move patients. So we're able to level the supply and demand in a way that we wouldn't get overwhelmed. So it's been a lot of learning on how to handle both COVID and non-COVID patients. And our stance right now is, how can we treat the maximum number of patients with urgent conditions to include patients who have COVID? Whereas early on it was treat COVID patients, pretty much everyone else wait. That's an overstatement. But now we're really learning more about how to treat all of them, which becomes incredibly important.
That's one of the things I wanted to ask, because there are obviously lessons learned in terms of having to go through things, whether you anticipate them or not. So part of what you've actually run down for us is what you hadn't anticipated in the beginning, but how that's actually helped you with your planning for any future pandemic. And of course, one of the advantages that you do have is that you're a network. You have a network across Texas, and you can move things around, et cetera. But getting ready for the next potential surge, and we know now that people just aren't paying attention. When you say there's 3 simple things you need to do: wear a mask, wash your hands, and stay 6 feet away. For some reason, some people are doing it, but many people are not doing it. So the concern then is we do have another surge, and the position that Baylor Scott White is in now to serve the population that it wants to serve in a way that's efficient and effective is what you're saying. This is what you're preparing for. What concerns do you have what is, I guess in my mind, I'm thinking, like, what concerns do you have if this were to happen? What things are still left undone that we need to think about?
Yeah, I mean, a big part of my job is worrying every day about these things, because we need to be prepared. One thing that many of you may have heard of is there is concern going into the winter months that as the flu passes through, there are more respiratory conditions that, on top of a COVID surge, could overwhelm our hospitals. And that becomes a significant concern of ours. The tightest aspect of capacity, when we look at capacity to treat a medical emergency, most people think beds, the number of beds. What we've learned from actually the previous surge is we are very innovative on the creation of beds. We can expand our bed capacity pretty significantly, and even the government can step in. And you saw in some communities they're using convention centers and pop-up areas for beds. The single biggest resource that's capacity constrained is actually trained staff, particularly critical care staff. So we worry a lot about that. Now, what happened in New York City with that is, if you looked at staffing ratios during their surge, it really stretched. Whereas maybe one nurse would be treating 2 patients, it stretched to 1 nurse to 4, 1 nurse to 5. And we don't want to be in that situation, because that situation is not ideal and is less safe. So that's one that we are focused on and worried about.
Well, this is one that, again, a policy situation. So when you think about certification and the different certifications in state, when you think about moving people across state, so pooling talent from Texas to New York, or New York to Alabama, or whatever we're going to do, if you do need, and if you can't, it's not like you can train people in 30 seconds and then they can get in there and work on these very delicate, very complex cases. But getting people from around the country to travel, Talk to me a little bit about your experience when that happened, because that did happen, and in the first surge here, and what kind of policies or regulatory relief would you need, or do you think hospitals need to allow that exchange of talent and trained professionals?
Yeah, I think it really requires it requires some preparation so that you're ready for that. Things that we ran into, as you might imagine, being a caregiver is a very personal, intimate profession, and requires really high trust between patient and provider. And what we found is, listen, to bring staff in from any state in the United States and bring them into our health system, they have to pass a drug screen. We need evidence that they've passed a drug screen. We need evidence that they've passed a criminal background check. We need evidence that they're truly licensed for what they do. And you think those are simple things. They really aren't. And what we need is pre-established reciprocal staff sharing arrangements that have that all taken care of, so that the time lag between a request that I would send to the Northwell Health System in New York for 100 critical care nurses to the time they arrive and start caring for patients, that we've narrowed that time lag, that the testing's already done, that at any point in time we have preloaded essentially staff that can move around the country and provide care where there's a crisis. It's one small but very important component to something that I think we need as a country, and that is a medical emergency response capability that is akin to FEMA, but is really focused on pandemics and medical emergencies, where some of these very unique resource sharing and resource provision needs to occur.
Is it happening? Is anybody thinking about this? Have you been asked to participate in any kind of, and if it's not happening at the federal level down, is it happening from the grassroots up, that's saying this is something we really need to do? And how are we doing this? How are we going about this?
Yeah, it's happening in pieces. So I don't want to paint a picture that it's not there. The state of Texas has certain regions for disaster response where there's been some resources to come from that. We've initiated discussions with other health systems to create these reciprocal agreements so that
excuse me, Peter, but has that been on like a state to state versus something at a national level trying to coordinate, or a regional level trying to, that's sort of your, it's an individual?
Yeah, it's really been health system to health system or within the state of Texas. I haven't seen much of interstate or a national approach to this at this point in time.
Mm-hmm. You would think that's something that, again, like you say, it might be a little thing, but being, especially in this kind of a state where obviously if you need somebody from another state, this is a life and death major event that's happening, and be able to move those quickly is really important. I was interested in is what movement, and part of the thing we deal with in disasters in the United States is we get through the disaster, we see it, we get through it, we want to make people well, and then you think about policies that could have been in place that would have been helpful at the time the disaster was happening, and we don't revisit those. We kind of, not that we go on to the next thing. And so I'm trying to figure out, like, what have we learned from this, and how do we help hospitals really prepare in a way that at least policies are not getting in the way and regulations are not getting in the way. They're more supportive of what's happening.
Yeah. I mean, there really is an opportunity to learn from this and develop a public health disaster response capability for our country. And there are so many lessons learned. The other obvious one was PPE and the PPE stockpile, wholly inadequate. There's another set of issues around manufacturing of critical supplies.
Yes.
There's a lot of discussion among health systems, as well as I know in government agencies. How can we manufacture certain critical supplies within the United States? We've entered into an agreement with a local supplier here in the Dallas-Fort Worth area for N95 masks, which we think is a much long-term relationship, is much more reliable source for a critical supply. So there are a number of issues there. I do think another piece is I think we're learning as a country that investments in public health and public health infrastructure and process is really important. We have a very, I would say, disorganized quilt of public health agencies across the US. We saw weaknesses in response on testing. We saw weaknesses and continue to see on sharing of consistent information, a consistent data set, guidelines, and then really prevention, really pushing forward public health prevention in our schools and the like. So there's a lot to learn from this, but I would say disaster response for a public health disaster, and then public health infrastructure are two very important areas.
Mhm. Well, one thing again, I don't know. You're in a place where you're seeing a lot of this information from your colleagues across the country, and then seeing this momentum. You know, there's one thing to talk about it and say we need this, and it would be good to have this and whatever, and still have some national approach to it or a state level approach. But the citizens in our state, we're going to take care of it this way. And this is something that I think is a policy school, and you know, you've been that. We need to understand how to make those things happen, how you become the catalyst or the glue that helps bring these different disciplines together to say, here's how we can help our citizens and if this happens again, because it is going to happen again. It may not be exactly a pandemic, but it is going to happen. And so that's the frustration I think I feel when I talk to people, that there's not a conduit for them to do this collectively. It's like, you know, entrepreneurial is wonderful. And, you know, you think about you found somebody to do the mask, but how do we actually lift this up for everyone? This is going to be a big challenge for our country, I believe.
Yeah, you know, one reflection is earlier in my career, I did consulting for the military health system. And within the military health system, as you might imagine, during peacetime, a lot of their facilities are used for, you know, not non-battle related injuries. In fact, caring for the families of military families and their hospitals and clinics throughout the United States and worldwide. But they always had a capability to respond during wartime, so that they had capability to deal with the conditions of wartime and the surge of cases during wartime, and had a mission to fund that standby capacity and capability. And I think for our civilian population and looking at pandemics specifically, there's some lessons we could draw from that. Now, is it going to be cost-free? No, it'll be money that will have to be spent to have standby capability. But in the long run, that policy and those programs will be cheaper than what we've experienced, and the damage, economic consequence, not to mention the public health consequences of the pandemics thus far. So U.S. is very good responding in crises, but I think in this case, we're going to need to learn from this and put some prevention in and some capacity into the system to handle this in the future.
No, I agree. I have a couple questions, Peter, in terms of the underserved or those that are fragile families or those that really, we're seeing this pandemic just rage through their communities. So has Baylor Scott White, you know, looked at that and said, how can we recalibrate our resources so that we have a special care for those particular communities or families, and how you can move that around and be, you know, using the data and the evidence you just pointed out at the very beginning of our talk. How are we preparing for people who are most vulnerable to this pandemic and to public health crises in general?
Yeah, I think it's going to take, there's not a quick fix to it, right? I think number one, on a policy perspective, you're going to see our health system, and I hope other health systems, I would imagine other health systems in Texas, really calling for expansion of coverage for the uninsured. So Medicaid expansion, which has occurred in many other states and has been you know, really a political hot button in the state of Texas. But again, I think there are some very strong arguments that by investing in the expansion of Medicaid, which would bring a very large number of the uninsured into the insured rolls, will then expand access. Insurance coverage is the single most important component to improved health and improved access. It opens doors to physicians' offices. It opens doors to getting preventive care in many different ways, and eliminates the barrier of the pocketbook, where someone puts off taking their drugs or their pharmaceuticals, their prescriptions, in favor of feeding their kids. So it's a very important component. I think beyond that, there are a lot of other tactics that many are using. We're trying to expand, again, our digital capabilities so that if you have difficulty in transportation, if you have difficulty getting to a doctor, we can still get to you, and we can treat you in a low-cost setting and diagnose what you've got, and regardless of where you live and how far away a facility is from you. So there's a lot of other techniques in that regard.
And some of those, obviously, you learned it was trial by fire. It's like, okay, these might be things that we would like to involve and investigate over time, but with COVID, it's the same thing at the university. You know, it was like remote learning. People were like, well, I'm not really sure. Well, when you had to do it, people did it and found some really efficient ways of delivering those services that will be operationally integrated into the system afterwards. So some of that is very important. What are you thinking about a vaccine? How are you, I just want to get your opinion about what you think, number one, the likelihood that we are going to have a vaccine by the end of the year. And I thought that's really unfair to ask you, but I'm going to ask you anyway. And then my thing is, how do we start planning for movement out of the kind of situation we're in now, where we don't have a vaccine, and we do have some, you know, we do have some ways of treating people when they do get it, but there's going to be a transition period of, you got it, who's going to get the vaccine, the ethics of who gets the vaccine first, the uncertainty of whether the vaccine is going to work in the total population the way we think it's going to work. And then from a hospital care perspective, how are you looking at that, how that rolls out? What are you, when you see this, what are you trying to see in this, in the future of vaccine?
Yeah, and I'm not an expert on this at all. I've read a lot about it. I think the optimism around a vaccine is the fact that we have 3 or 4 different types of vaccines, that underlying techniques, and they are moving into phase 3 trials. Mm-hmm. So I think that's very, very, very positive. And I think recently the manufacturers are committed to safety and have reinforced that commitment to that they're not going to rush a vaccine unless they know, based upon their protocols, that the vaccine is safe. I think that's all very, very positive. And I'm very optimistic that there'll be a vaccine. The phase 2 trials have shown in virtually every one of these that are moving to phase 3 that the immune response of patients who've taken these trial vaccines has resulted in antibodies that are a stronger response and more of them than even the plasma of patients who have had COVID-19. So we're seeing some very positive signs there. Now the timing's another matter, and everyone's got their best guess. But I do think your question about rollout is crucially important, and you know, it should be prioritized. There's a pragmatic approach to prioritizing it. Frontline healthcare workers and first responders need to be near the top of that list because, as we said earlier, they're an important resource. They're an important capacity constraint in the treatment of the disease. If many of them are out sick, we're going to reach a capacity limit in the surge, which I mentioned, staffing being the most critical. So keeping them healthy is a very important first line of defense, so we don't have preventable mortality occurring from healthcare workers that are sick. I think those in high-risk categories, again, that are at risk of death as a result of the disease should be high up on the list as well. It's one thing to get the disease and be treated for it. It's another, again, to experience preventable mortality from the disease. So I think there's a layer of nursing homes, the elderly, people with multiple conditions that will have to be prioritized in this. So I think it's a massive undertaking, but safety first, and then getting it to those that are most in need as early in the process as possible. And then it really causes us to the other part of your question: what does a post-pandemic world look like?
Yeah.
What things stay and what things go? And I'm sure there's going to be a lot of just cultural Americans. Hey, let's go back to pre-COVID and live our lives the way we did before. But I think there'll be aspects that we're going to say, hey, we learned during this and we really like it. And there are issues of workplace. What will that look like as people have experienced both the pleasure and the pain of virtual work, and sometimes it works better for certain types of tasks, and sometimes it doesn't. But I think we'll see an evolution in how the workplace functions. I think specific to healthcare, one thing that we've learned about virtual and learned about this is the healthcare system is designed to be excellent in individual pieces of the care continuum. But where the pain points are the connections between them. So an example would be a COVID patient who is admitted to the hospital. We're treating them well, they get better, but now they go home for recovery. How are we connecting those two things? How are we orchestrating the follow-up care for the patient who goes home? How are we ensuring that their family members are healthy and stay healthy? So I think you're going to see the application of digital tools and health systems really focus on this orchestration issue, because the pain points in the U.S. healthcare system, A, they're on coverage, and then B, they're on the handoffs as you pass through the healthcare system and really closing that loop. And I think we've learned a lot during the pandemic there.
Well, one of the things we haven't talked about, which is really essential, we mentioned it a little bit, is the professional capacity. So, the shortage of nurses, the role of EMT people. I mean, all of those are things as well. And when you start thinking holistically of the whole system, the folks who, it's all human capacity and the knowledge that they bring to this. And so we have our challenges ahead there as well. So, you and I have been talking about things, and what I keep thinking and what I see is this holistic picture of what needs to be done in order to really move this forward. And yet we're a very bifurcated, very kind of siloed society in the way we attack issues. But the capacity, the human capacity and the knowledge that capacity brings to the healthcare system is so important. And I think what other people saw was the importance of EMT. They made life and death decisions about where to take people, and they were often the ones who were the last people that patients saw. And we have to understand that. That's another thing we have to start thinking about, is where the brunt fell on certain people and their training and the lack of, the shortage of, for many reasons. But that's another concern I have.
Yeah, and a more acute concern just today in that regard is, you mentioned things that I worry about. On my list is the burnout of those.
Yeah, yes, yeah.
These are incredibly committed people. They went into the profession to care for people. They will be there when needed. And many of them have been working continuously since mid-February and haven't taken any time off. Some have been isolated from their families, particularly during these surge periods. So it becomes really hard. And then particularly as some of the healthcare workers that have young families, they're going off to work every day, and now they've got kids at home who are in a virtual classroom. And how do they balance that? So really worried about burnout, and it's something that we have to do a better job at, we as a healthcare system, and really looking at ways to do that. But that's one that's crucially important.
Yeah, well, the emotional toll of being the family, at the end of life, being the person that someone sees, the emotional toll of that and the frustration of not being able to help somebody survive after caring for them for so long. So there's so much involved in this. I just hope we can learn from this and that we can take the good lessons and move those forward and get some of the obstacles out of our way as we move into not just what might be a second surge. But just in general, just to help us, that using this pandemic to help us elevate our health system, access to that system, our public health system, our financing. We should really look at this as an opportunity to, reset ourselves in a lot of ways. So before I have one more question, then I want to go to the questions that have come in. What are you seeing as a likelihood of either a spike or a surge? Are you seeing some things that we're in danger of experiencing in Texas, a second surge?
Yeah, well, number one, I'd emphasize that we're prepared for it. We as a healthcare system are preparing for multiple surges until there's wide distribution of the vaccine. So we're prepared for it. We're worried about a surge in October. If you go back and look at some of the timing of the surge that we saw pretty much the full month of July, the roots of that really went back to approximately Memorial Day. And really started seeing it grow in late June and then began to really rapidly expand. We saw admissions increase almost fourfold from April, and we compared it to the surge in July. So what we're concerned about is seeing that again in roughly October, and then you take the risk of flu that will continue through the season. You've got kind of a double whammy going on there. So we're worried about it. We're worried about it. But again, as I mentioned earlier, we know a lot more. We can move ventilators throughout the system. We can move staff through the system. But at some point you reach capacity. So we're concerned about that occurring.
Yeah, and the unknown of the interaction between the regular flu and the pandemic, that's an unknown as well. So the virus is again saying, okay, I'm here now. This unanticipated interaction may be a whole nother issue.
And as the infection rate goes down in our communities, there's human nature is to let your guard down. So, I worry about less mask usage out in public, less physical distancing, and as that happens, we know that transmission will go up as guard goes on. And also the universities are back in session, so you're going to have higher transmission out there. So it's a tricky thing, and particularly this virus where some estimates are up to 40 or 50% of positive patients don't have symptoms.
That's the scary thing. That's the scary thing that people are walking around. That's why testing is such an important part of this whole treatment. And this is a problem. We've just talked about the availability of testing, and also people being concerned. People concerned about not going to get tested for whatever reason, being concerned, and I'm not taking the vaccine because I don't trust it. So we have a lot of public education to do as well from our perspective. But Peter, I do want to get to some of the questions. There's a question here, and this is one about the health. This is the health information exchanges, and Maddie has asked this question. And given that how they've helped contact tracing, how have they helped contact tracing and is there renewed enthusiasm for the health information exchanges? How have you seen those work?
Relative to contract tracing, I have not seen them work very much in that regard. The problem that we've seen in getting contact tracing off the ground has been in the turnaround time on testing. Mm-hmm. So if someone is positive for COVID and doesn't know it, and then they get tested, that delay time expands the horizon of transmission and then really hampers the practicality or even the capacity to do contact tracing. So what I am seeing is in some controlled environments, universities as an example, the application of contact tracing can work pretty well because the population isn't necessarily circulating as much in the general population, and you can actually document the contacts and then effectively quarantine those that have been in contact with a COVID positive patient. So that's where I've seen that work. I think the exchange of information, it hasn't really contributed much thus far, but becomes crucially important. I think it becomes really important as medical records become more electronic and more transferable. It becomes crucially important as we start to see cohorts of post-COVID positive patients that have been having other conditions, that it's tracing that and understanding their medical history. Again, I don't want to go too far down that track. I'm not a physician, so but I think the information exchange, the facilitation of that among health systems and hospitals and clinics can only be good, because it will provide better treatment of patients, but then also provides better ability to find insights to what works through analytics.
One of the things we've seen is the concern that people have about confidentiality. You know, if they go and they get it, and you know, then they talk to other people. So convincing people that there really is, and honoring confidentiality is another issue that we've seen in terms of people's reluctance to get engaged in contact tracing, or to, you know, they get in, they're afraid of it. So that's another challenge I think we have, ensuring people that confidential medical records will be kept confidential medical records, and at the same time being able to share that information in a pandemic like you wouldn't share if someone had high blood pressure or had heart disease.
Right. But this goes back to investment and planning around public health crises. I mean,
yeah,
you know, we don't have uniform employer policies around protection of employees who disclose a health condition they have that might put others at work risk, right?
yeah.
People are fearful. Some people are fearful that by disclosing that in some way, they're going to put their jobs at risk, or there may be some other consequence. And I think all that isn't adequately handled during the crisis. It's something that has to be handled during a period of calm, and we can get to better public policy.
There you go. Another thing on the list of to-dos in terms of lessons learned and how to ensure that those are not obstacles in the future. I have another question here. It's from Paul Kincher. According to the New York Times this morning, AstraZeneca had to suspend their vaccine trial due to complications, so we knew that. Do you foresee further interruptions with other drug companies moving forward? And what should the general public understand about these setbacks and what they need?
Yeah, I you know, again, you know, what I understand about that particular case, they had one patient that had a concerning response, and they're taking, the good news here is they're stopping the line and they're saying, we're all about safety, and we are going to do a root cause analysis of this particular patient and what happened to them to understand whether this secondary condition that they have is caused by the vaccine or is it unrelated. And rather than just pushing full forward. So they're following their safety protocols on the development of a vaccine. So I personally see it as a very positive thing that they're not rushing through, and they're making sure they're careful about it. Because, you know, you look at vaccinating the entire human race, if there were a safety concern, that is pretty devastating, right? So they're being extremely careful, which I think extends, you know, this hope that we have one right away. I think this appropriately extends that timeline so that we know when the vaccines come out that they're both effective and safe for the general population.
Mm-hmm. Yeah, I was thinking about this when I heard it as well. It's like the timing of this is really very good, because it's just saying, okay, everybody, look, you know, even though everyone's very anxious, you know, you want to get this done We want to make sure people are well. This takes time, and science is where we have to go. We have to really depend on those who have the ability and the knowledge to that we can trust them. And so I think this came in as like, this is a big company, so this isn't about money. In the long run, it's about like whether or not their vaccine is going to work or not. They're not going to do no harm. But it's also a big company saying, hold it, we've seen something we don't like here, and we want to hold back on. And I think it just added to the conversation a dimension that we were missing before they announced this. So I think that's a good question. Peter, we got a few more minutes. What would you like to tell people who are listening in about, especially your role, Baylor Scott and White, what you're doing and what you're trying to do, anything that you think that would help them understand from, from your perspective, what the medical community is dealing with and what kind of cooperation we need from the general public?
Well, you've heard it a lot, but I'll say it again because it works. Wearing a mask, practicing social distancing, 6 feet from others, and personal hygiene, washing your hands, following those 3 very simple steps will reduce the transmission of the disease, and by doing so, will prevent unnecessary deaths, particularly high-risk individuals. So and consistently doing that, and even if you're in a low-risk group, is realizing that you're part of a broader community and you have an obligation to others as much or more than you have an obligation to yourself, and that by wearing a mask, you're protecting other people. And I think as a society, we need to just constantly be reminded of it because it's uncomfortable, because sometimes you can't see the effects of the disease. Our healthcare workers see it every day. They're highly attuned to this, but I would just reiterate that and try to reiterate that in every discussion that we have, because that will keep the numbers down to the point where the healthcare system will not be overwhelmed by what we would anticipate recurring increases of the virus until we have a broad-based applied vaccine.
Peter, I have one other question that we didn't get to, and because you're such a big network, so you have hospitals, and people think about hospitals, but you also have clinics. You have a lot of clinics. What are you seeing differences in the care that you're giving and the kinds of engagement you have at a clinic level versus the hospital level, and if they've helped inform each other in terms of how best to prepare especially for the COVID populations?
Yeah, one example I would get on part of your question is how the 2 settings informed each other. Early in the pandemic, most of the interaction with COVID positive patients by healthcare workers was in a hospital setting, right? Most of the clinics were closed. And what we found, and we continue to find, is that for those healthcare workers that have been in direct contact with severely ill COVID positive patients, those healthcare workers that have followed precautions, the infection rate of those healthcare workers in total, and they may have gotten infected in the community, whether it may or may not have been in the hospital, but if we look at it in total, that infection rate is below 1%. Mm. So that's still too high,
yeah,
but yeah. And what we did is we took those learnings and then applied it in the clinic, in the ambulatory environment. And we wanted to do that, and we continue to want to do that, so that it is safe in that setting. And the message to those patients that don't have COVID but have an urgent condition is it's safe to go to your doctor, it's safe to go to a clinic. Just follow the precautions that they tell you to follow, and those healthcare workers will follow it, and you will have a safe encounter. In fact, that environment is probably safer for you than some environments that you're already participating in the communities, be it a grocery store. So that's a big learning, whereas early in the pandemic, we didn't know that. We really didn't know that. The precautions work.
And are you seeing, okay, you're saying they work, so that, you're seeing people have more confidence in coming to the facilities because of the track record on this, et cetera, right?
Yes, yeah. We've seen a big change in that, and really a big snapback in patients coming back. And some of that was postponed care from April, but we're seeing a consistent trend of patients being more confident to come back into our clinical settings because of the safe environment that we've created. And we've seen a higher demand of patients seeking care virtually, which has really been a nice development and very convenient for our patients.
Well, Peter, I want to thank you so much for taking your time to be with us. And, this In the Arena series has been a really popular one for two reasons. One is we get people like you who just are in the thick of it, who can answer questions and have a conversation. And the other part of this is that it's on our YouTube channel, so people can go back and they can look at it and refer to it. And it's been very useful, so I thank you. And I thank you on behalf of all of us for being in this really important career trajectory. And also on our behalf, we'd like you to thank everyone who's working in the healthcare system. We depend so much on them, and sometimes they're not paid what they should be paid, and that could be a whole nother conversation. So I really do thank you for this, and I thank everyone who's been listening to us as well. Before we sign off, there is one thing I do want to do, a little advertising. And as we have noted throughout this year, the LBJ School is celebrating 50 years of educating the best and the brightest thinkers and doers. You just had one here today with Pete. I'm thrilled to announce today that this fall, we will be hosting 2 virtual celebrations of this momentous anniversary, one on October 5th and one on October 12th. They'll begin at 7 p.m. Central Time. These 2 forums, one's called The Destiny of Democracy, and the other one is called Humanity, It's Time. And we will take a look at how LBJ's legacy lives on today with some of the country's top leaders in business and philanthropy, healthcare, space exploration, and more. I invite you to visit our anniversary website in coming days at lbj50.org to see the full lineup and in order for you to RSVP to participate in this. So thank you again, Peter, very, very much. Thank you, everybody who stuck with us on all of this, and I hope you learned a lot, and we'll see you next time. Thank you again so much. Thanks, Peter. Appreciate it. Okay.
All right.
Bye. Bye.